Hello, Dr. Desiree. Welcome to webinar. Yes, you're audible.
Okay, let's just give 5 more minutes for others to join and then we will start, okay?
Yeah, sure.
Thank you. Good morning or hello guys, welcome to our Ebcog webinar, back-to-back webinar. How are you? I'm Dr. Desiree. How is everyone doing? I don't get an answer. Everyone is fine? Dr.
Hello, Dr.
Faisal.
Desiree.
Hello.
Hello, Dr. Desiree. Welcome to webinar. Yeah, good to see you. And yeah, students are here and we can call them one by one as well. Yeah.
Yes, Dr. Ramesh, Dr. Zasha, Turani, Orlando, Dr. Ramanikam, Dr. Tahira.
Yes, students
you
can
for
one by one open their mic and they can introduce themselves. That would be a great thing.
Anyone want to talk? Have you enrolled in the exam? Have you registered in the exam? Or not yet? You're still confused whether you have to take this exam or not. They are very silent. Okay, let's start the webinar. Thank you for attending this webinar. I know that it's a Friday and most of you are off, and thank you for giving us your time to join us in this webinar. First of all, I would like to greet everyone, Adha Mubarak, okay? And also advance happy Father's Day to all fathers out there. Okay, it will be on Sunday. So why did we conduct this webinar? So that you know the benefits of becoming an Ebcog, a fellow of the European College. Okay, so once again, I would like to welcome each and everyone to our MedExam Expert Ebcog chapter. Okay? So what is Ebcog? I know every one of you are familiar or once you have heard what is Ebcog. So Ebcog is the European board was founded in 1952 to protect working conditions in this medical specialty under the European Union of Medical Specialists, that is UEMS. And it was founded in 1991. It consists of 4 offices and 36 member countries, as they say before. But actually, there are only 34 member countries. Okay, you can see in the screen. So we have here, let me just put on my laser pointer. Okay, you can see here all the European countries, and you can see here 3 asterisks for United Kingdom because the UK already exit the European Union in 2020. And the Russian Federation is temporary membership is discontinued because of the war with Ukraine. So their status is under they will only be continued, the membership will only be continued if they will pull out the military action or forces from Ukraine. And Israel is under member status. So without this, maybe there will be only 31 member countries. Okay, so what is the history of Ebcog? So Ebcog before, they only conduct once annual exam. Okay, one exam for part 1 and one exam for part 2. It started in 2016. The very first knowledge-based assessment exam was held in Italy. And our very esteemed mentor, Dr. Muhammad Hassan Mahmoud, is among these 45 who passed the exam. Actually, during those times, it was a very difficult exam because the exam format has MCQ, EMQ, and SBAs. Okay, but now, I'm not saying that it is easier now, but of course, it's more difficult to have MCQ, EMQ, and SBA in one. So that's why a lot of students now are wanting to take this exam because of the change in the exam format. The first ever OSCE exam was held in Norwich in England. And you can see here in 2017, it was held in Turkey. So it rotates among the European countries. And then until 2020, the Part 1 exam became a remotely invigilated virtual examination. That means you can take the exam at the comfort of your own home. So that means it will be less expensive because you don't have to get visa, you don't have to travel. Unlike before, you have to go to Italy in order to do this exam face to face, but it's still computer based, okay? And from 2021, the OSCE were held in Lisbon, Portugal. Until last year, there were two exam centers in Portugal and in Dubai, but it was simultaneously done in 4th and 5th of November. But for this year, the change in this year's exam pattern is that there will be two written exam. The one has already finished in March, and then the one will be in August 31, and then the first OSCE will be in June in Portugal and in Dubai in November. So you can see it will not be synchronous like last year. Last year, same time, November, both centers. But for now, in June, it will be in Lisbon, and in November 9th, it will be in Dubai. Okay? So, as I've mentioned, the Ebcog Fellowship exam has two parts, okay? Unlike your MRCOG, which has three parts, your Ebcog Fellowship exam has two parts. The first part is a knowledge-based exam, and it's computer-based, conducted by Ortrac. Ortrac is a Swedish company, okay, that is conducting this exam, just like your Prometrics for your MRCOG and your Test Reach for your MRCPI. So this will be conducted by Ortrac. And part two is an OSCE exam, okay? Usually the seats are limited, but what is good about EBCOG examination is that you don't wait for too long to get this eligibility, okay, or confirmation. So once you applied, within 1 week, they will confirm, okay, because the exam is not yet saturated, okay, the college is not yet saturated. But as you can see now, they are holding two exams. That means it's becoming more popular, just like your MRCOG and your MRCPI. Okay? So you can see when you open the website of EBCOG, you will see this portion. Okay? Part 1, exam, KBA, which I said the registration is also is already closed. It has finished. And then part 1, exam in August. The registration is still open until July 31st. And then you have your OSCE in June and another OSCE in November. Okay, so a lot of students are asking, what are the eligibility to take this exam? What is needed in order to apply for this exam? And most of the students are afraid to open this, they're afraid to click this registration. But if you don't click this blue button, you will not, you will not find the eligibility, okay? So you have to click on the registration, and then it will lead you to this page. Okay, you can see here the efog Part 1 KBA 2024 August. So it will have your important dates. It opened on October 4th, and it will close on July 31st, and the exam is on the 31st of August. Okay, so it's a one-day event, remotely invigilated exam, virtual exams or RIVE, and the fee is 650 euros and additional 100 euros for non-EU residents. Okay, it is divided into two parts: 100 initially, which is non-refundable, and the remaining if you're eligible to take the exam. So at the end of this page, you will see here, you have to sign in with Ortrac, or you have to create an account. So you will see this Ortrac page wherein you will put your email and your password, and then you will click sign in. And once you have filled up, or you have make an account with Ortrac, okay, it will lead you to this page, okay, the application form. So don't be afraid to open it, okay? So because it will not be sent unless you send it. So you have to put your first name, last name, nationality, and if you are an EU resident or no. So by default, you have to be careful. By default, it says here yes. So you have to click no, because if you are not an EU resident. So these are our most common questions. So what are the eligibility in order to take this exam? First, you have to have your primary medical degree. Hello. Hello. Hi. Please mute your microphone. We will appreciate it. Thank you. So the candidate must have a primary medical degree. That means you have to finish your medical degree. And not only that, you have to be registered in your as a medical practitioner in your own country. Okay, not just finishing a medicine. Okay, and for those who are in the UK, in the Europe area or the EU area, they can take this exam in the last year of their national specialist training. Okay, all candidates must have at least 4 years of postgraduate training post. That means you have finished your residency training in OB-GYN. You have to be an OB-GYN specialist in order to take this exam. So if you have not yet finished your residency training, don't try because you will just lose your 100 euro application fee, okay? And they will be asking you to provide evidence of your good standing, okay, and your clinical experience. So you can see here in this page, you have to upload the file for basic medical degree. You have to upload your registration in your own country's license to practice, a photocopy of your identity card or your passport, and proof of clinical experience. That means this is your residency training certificate. And then once you click submit, okay, you will see here that your application form information is finished, application form. So once you click the submit, okay, it will lead you to this page, the payment of the administrative fee. Okay, this 100 admin fee has not changed since 2017. So you can see this is the application of Dr. David Headland. I took this in the internet. So it's payable to using
Dr. Desiree, can you please check your mic? You're not audible.
Can you hear me now?
Yes, Dr. Desiree, you're audible now.
Okay. I'm so sorry because, I traveled. I am not in my home location. I traveled from, I am now in a hotel. So, okay. Let me
Yes,
share my screen.
definitely.
Is my screen visible?
Yes, it is visible now.
I'm so sorry for the delay. Okay, so once you submit your application, then so what will make you decide? So I'm here to convince you, actually. Okay, so let's go to the next. So what are the benefits of becoming an EBCOG? And then I will answer all your questions in a little while. Okay. Um, so number one benefit of becoming an EBCOG is that it is a prestigious title. So imagine if you take the MRCOG exam, um, you are recognized whole world, but you can, of course, practice in the UK once you get registered with the GMC. Okay. And for the MRCPI, you can also practice in Ireland once you get registered with the Irish Medical Council. For the EU, okay, this consists of, as I've mentioned, 30 to 31, 33 member countries. And if you pass this EBCOG exam and become a European fellow, and you fulfill all the other criteria for each country. So imagine 33 countries, they have different um, council. Okay, they have different licensing system. Okay, so I'll explain to you in the next few slides. So it provides an opportunity for all OB/GYN trainees to assess their knowledge against international standards. So this is what I'm saying. If you are training in the EU, you can assess your knowledge before taking the national council exam, the national exam for in your particular country. Some countries in the future may choose to recognize European assessment as complementary or equivalent to their national system. So it is going there. Okay, so, and you will understand and you will feel that as we go along, it will become more and more difficult because the exam will become more and more saturated, just like your. Remember, before it was only MRCOG, and now the MRCPI is becoming saturated also. So maybe a few years, 2 to 3 years, EBCOG will also become saturated. Okay. And another perks of being an EBCOG is that it allows you to become a fellow, automatic fellow, once you fulfill the criteria of the American College of OBGYN. Okay. So I would like to share you this pro forma. Okay, we have a fellow, European fellow who is from Oman, I think, and he passed this European board exam. And she submitted this, the hospital wanted her to submit this pro forma for the training title qualification. So let me read it one by one so that you have an idea. Okay. So the mode of entry admission to this diploma or degree, it's both. So written exam and interview. The percentage of applicants who got admitted is 40%. And the eligibility criteria, you should be an OB/GYN specialist, 4 years training. Okay. Please specify if the course is based on full-time, part-time, or distant learning. So it's part-time. Okay. Because the OSCE is face-to-face and the written is distant learning. Evaluation of the conferred awarded qualification was by written examination and OSCE. Duration of study, actually what Alexandros wrote here is that Alexandros is the exam secretariat. So if you have any question regarding the exam, you can contact him on his email, which is you can see in the website, and he is very, very accommodating, okay, and very, very kind. So Alexandros right here, the date that the person passed the part one, and then the date the person passed the OSCE. Okay, so let's go to the next page. I think this slide will clear all your questions. Okay, before award of this degree, is there an exit exam? Yes. What is the mode of examination? Written and practical, viva. Is the degree awarded directly related to medical? Yes. Whether the above degree has been issued by a legally constituted authority, which is the EBCOG? Yes. This is one question. Okay, whether the above qualification is registrable by the statutory institution authorized by the government? No. Okay. So you cannot register this qualification Is the holder of the above qualification allowed to practice as a lawful healthcare practitioner in any country in Europe? No. But there is a reason why, okay? Whether the holder can be qualified to be holding a position of consultant in your hospital or country? No. And whether the holder of above mentioned qualification can be holding a teaching job? Okay, so why is it no, no, no? As I've mentioned, you have to fulfill the criteria of each and every country that you are going to apply to. Okay, so for example, wait, okay. So for example, you wanted to go to work in Finland, okay? As we know, Finland is the happiest European country. So if you wanted to work in Finland, aside from being a European fellow, you have an edge. However, you have to undergo all these criteria that the Finland require. Okay, you have to have a 6 months internship in Finland. You have to have language proficiency requirements. So this is mandatory in any European country. So if you go to Finland, you have to study Finnish language. If you go to Germany, you have to study German language. And you have to take the Finnish examination. So aside from the EFOG European Fellow, you have to pass the examination that will be conducted by Valvira. Okay, Valvira is an central agency operating under the Ministry of Social Affairs and Health, under the MOH. And then once you pass this exam, the Valvira will give you a limited license to practice, okay? So in Germany, it's different. So of course you have to pay fees, okay? In Germany, it's different. So in Germany, you have to finish C2 level of German language, and you have to have this approbation. Approbation is, that means even if you graduate from outside the EU country, they will check your credentials, and if it fits the German national training, then they can give you an approbation, okay? So this is the reason why I am telling you that it cannot be registered unless you fulfill the individual criteria of each particular country. Just like in MRCOG, as I've mentioned a while ago, you have to be registered by the GMC, and you have to be registered with the IMC for Ireland. Okay, so this is one good thing about being a European fellow. You can apply as a fellow of the American College of OBGYN. So you can see the ACOG, the American College of OBGYN, only recognizes 10 member society, which is the American Board, if you pass Part 1 and Part 2 by the American Board, the MRCOG, MRCPI, not included, okay? So only MRCOG, if you have finished the 3 parts, you can apply for ACOG. Royal College of Physicians and Surgeons of Canada, the Mexico, okay, Mexico Gynecologic and Obstetric Society, West Indies, the RANSCOG, or the New Zealand and Australian board. Then you have your Central America, Japan Society, and you can see here, you have your EBCOG. This is how I got my ACOG qualification. So after I passed my European Fellow, after I become a European Fellow in November, I immediately submitted they only asked me for one license to practice in Saudi Arabia. All of the other I provided already, and they require the current license practice because they don't want to have gaps in the work. So you have to prove that you have license in the place where you are. If you are in Dubai, you have to give your license to practice in Dubai. And then you'll just have to wait 2 weeks, and then they will assess your credentials, and then they will give you your certificate that you're already a fellow of the American College. Okay, so having a European college, you are a fellow of the European College, and then a fellow of the board of the European College, and then a fellow of the American College. So what else you will be asking for? It's a 2-degree-in-1, hitting 2 birds with 1 stone, right? Okay, so now let's go to our courses. We will be offering courses for this year, Part 1 course, which will start in
Dr.
July.
Excuse me to interrupt you.
Yes.
Can you repeat to that? If you have European board, can you apply for American board?
Yes, can I repeat?
Yeah, please, please.
Yes, no problem. Okay, so you can see here, if you open the ACOG website, so there's an app, My ACOG, okay, My ACOG. So if you open the ACOG website, there's a criteria in order to become a fellow of the American College. And you know, when you are American fellow, is a European fellow, is another feather in your hat, right? So in order to be a fellow of the ACOG, you have to pass all these board certificates. Okay, you have to become a fellow of all these. Not all, only one. Okay, so if you have passed MRCOG Part 3, finish, you have to submit that certificate and apply to the ACOG, and then they will assess your credentials. They will ask for another credentials to provide. If it's everything, you will get an email that already accepted in the college. Okay, so what I'm saying is, when I pass my European board, because I know of this, okay, so I immediately in November I passed. So in December, not December, in November I passed the EBCOG, and I applied in March, and then they conferred me the fellow status in April 1. So the membership usually starts in April. Okay, you have to pay every year annual fees. Okay, is that clear?
Yes, yes, Doctor. Thank you.
Okay. Okay, so yes.
Excuse, can I ask one question? If they give the fellowship, that means American college, is it equivalent that they that can be we can work in America or not?
Every qualification, as I've mentioned to you, it's like someone with your American fellow certificate is better than those without fellow certificate, right? But you have to, as I've mentioned, like MRCOG, MRCPI, you have to be registered. You have to be registered in that particular country in order to work in that particular country. Okay. Any
So
other
that
questions?
means that is not as equivalent to work over there.
No, everything, even the MRCOG, the MRCPI, it's just a qualification that makes your status higher than anyone else.
Okay. Thank you so much for your answer.
Welcome. So we will be having our courses, part 1 and part 2, because before, in the previous years, we don't have so much time. So we will be doing an intensive course, which will start in July, just enough to prepare all of you for the August 31 exam. Okay, so this will be 5 weeks, a question and answer type with rationalization. We will be discussing with you some previous exam questions in the course, because we are holding previous exam questions from 2021 to 2023. So we will be discussing that during the course. And for part 2 course, after the part 1 course, maybe we will be doing the part 2 course. It's just a perfect preparation for your OSCE. And then we will be having an on-site course probably in Dubai. Okay, these are all laid out in as a plan. Okay, but for now, we are accepting enrollees for EBCOG Part 1 course, and I know the team has prepared a very big discount for you for all those who attended this webinar in celebration of the Adha Mubarak, of the Eid al-Adha. Okay. So we will be your mentors, Dr. Muhammad Hassan Mahmoud. Okay, as I've mentioned to you, he's one of the first who passed the EBCOG, so you can learn from him, from his experience. Okay, but during those time, Dr. Muhammad Hassan Mahmoud has a more difficult exam because it has 3 MCQ, EMQ, and SBA. Unlike my exam last year, I only have SBA and EMQs. Okay. You see, imagine yourself having this EBCOG, efog, EBCOG, and FACOG, okay? So, and also before, there is no reference for EBCOG. During those time, we are using all those available books by the MRCOG, and the guidelines by the NICE, by the MRCOG also, we will still be using it. But our priority is the Ebcog book published by the Ebcog itself. Okay, and then we have 2 volumes. You have your gynecology and your obstetrics and maternal fetal medicine. And for those who will be enrolling in the course, maybe we will be providing with you the PDF. If you don't have this book, we'll be giving you the PDF. Okay. And then these are the SBA references. You have your first edition, efog. You can see MCQ, AMQs, and SBAs. And we have your second edition for efog, AMQs, and SBAs only. But this is still is still not yet published. Okay. And then the third reference is your SBAs and EMQs. I know you are familiar for those who are taking MRCOG, Shirlita Data, and your respected Tahir Mahmood. Why we choose this book? Because Dr. Tahir Mahmood is a previous president of the Ebcog. So you can see how he thinks, and then, you know, maybe it will be included in the exam. What else we will be providing you? So we'll be providing you a PDF copy of this. Okay, ultrasound in obstetrics. So anything in the first trimester ultrasound, early pregnancy, we will be using this reference. Okay, European practice in OB-GYN, ultrasound in obstetrics and gynecology. And for cervical screening, cervical cancer screening, because you know, the MRCOG has a different reference, and the cervical check for MRCPI. For the European Union, we will be using these European guidelines for cervical cancer screening. And then, of course, we have guidelines from ESHRE and ESCO. Okay, we will provide this to you in summarized form. Of course, we will be also giving the PDF in your platform, in your portal, but we have summarized forms of this, and we have summary also of your NICE. It will be provided in your library, the NICE, the BASH, the GTG, what else? Everything that the TOG, okay, it will be provided that in your platform, in your portal as a summary. Okay, so what is the exam syllabus? Okay, so you can see here, this is the actual exam result. Let me focus. So this is an actual exam result, okay? It's a very, very detailed result, not unlike your MRCOG and MRCPI. So in this way, you can see which area you make more mistakes, right? So in the passing mark is low, okay, 52.8 and 59.3, but it usually adjusts depending on the performance of the group who took the exam, and it's also using the ANGOF method. Okay, so for obstetrics, we have prenatal care, intrapartum and postpartum, general management, knowledge and skills, and obstetrics. Okay, there will be very, very little or subtle differences between the MRCOG and MRCPI and Ebcog. So if you're preparing for MRCOG and MRCPI, might as well prepare for Ebcog. So you can have, you know, 3 degrees in one in one go. So for gynecology, these are the syllabus: benign gynecology, reproductive medicine, urogynecology. Okay, so this is it. Okay, I just put it here. Hello, hello. What are you saying? Wales, Dr. Rahman, is Ebcog also recognized in Wales? Before, maybe, because Wales is in England, right? And England already exit the European Union. But of course, it's an international, worldwide recognized qualification. So it's recognized everywhere. But it doesn't mean passing the Ebcog, you can work in Wales. Okay? So next. So the pattern, as I've mentioned, SBA, you are all familiar with SBA pattern of the exam and the EMQs, right? So we will not be discussing this. This is just to show you how we go about the course. So you can see here, this is an exam question taken from the Ebcog 2021 recall. Okay, 27-year-old. So we have here your question stem. And in SBA, you have your 5 option. And in the course, me and Dr. Hassan will be explaining to you why we choose this answer. Okay, so the answer in the previous question is C, or reassure, because according to the book which I mentioned a while ago and the European guideline, the herniation begins at 8 weeks and ends at week 11. So fetus older than 12 weeks do not demonstrate any signs of mid-gut herniation. So the answer here is reassured. And you also have your EMQ. So you are all familiar with EMQ. So what is good with Ebcog EMQs is the scenarios are limited to 3. Okay, there are not too many scenarios. Not like your MRCOG. Sometimes there are 4 scenarios. There are 5 or 3 or 2. Right? In Ebcog, the EMQs are fixed into 3 scenarios. Okay. And there's a topic. So when there's a topic, usually, of course, they will not write nerve injuries, okay? But you can see in the questions, so you have here the same, you have your options, you have your lead-in statement, and then you have 3 scenarios, okay? So this is an EBCOG 2022 recall exam, recall question. So you can see here, it's all related to the nerve injuries, okay? So if you can see gluteal, vulval, and perineal pain, so you will think of pudendal nerve, right? And then if you have your status post TAHBSO for cervical cancer with lymph node dissection, of course, you will think of a more deeper nerve. Okay, so that will be your genitofemoral nerve. And for fine and steel with sharp incision affecting the labia and the thigh, so what are you thinking about this? You're thinking of usually your sorry, the slide becomes 2. So usually your what? Your ilioinguinal and your iliohypogastric, because this is a fine and steel incision, so they are at risk of being damaged when you extend your incision. So this is how we go about the EMQ and the SBA in the course, okay? So remember, stay inspired, never stop creating a better version of yourself. So if you're thinking there is no any knowledge that is wasted. So anything that you study, you gain it, okay? Not only for disqualification, but also during your practice. You can see, after I become the EBCOG fellow, my practice changed. Because before, you are not following, also for MRCOG and MRCPI, because you now have a guideline to follow in your practice. And usually, if you have a guideline to follow in your practice, that means you are practicing safe medicine, safe for your patient and safe for you. So you'll be safe for malpractice problems. Okay, so if you don't have any question, do you have any questions? So, Anam, is Dr. Hassan with us now?
Yes, I'm here,
Hi,
Dr.
Dr.
Desiree.
Desiree.
Hi, sir.
Yes,
Why
he
you're
was
so
listening.
quiet?
He was
I'm here from
listening
the start,
quietly. He was
and I'm
the
just
audience
following
today.
your very interesting session. Actually, I just discovered a lot of information about the ACOG and how to do this stuff. So I'm very happy and proud of you, and
Thank you,
I'm
sir.
very happy to be with all these friends and candidates in the session with us today. Just the introductory session for the expected great course of ABCOG indeed. So I'm happy with that, and I'm very happy and proud as well to join you, Dr. Desiree, because you know that I believe that you are the most intelligent and brilliant doctor I ever met, because you can just understand statistics. so so
Thank you, sir.
the only chapter I went through many exams, I never studied it and I never being able to understand it clearly, but you did, and you are amazing in many other difficult subspecialties. So I believe you are very brilliant one. So I'm very happy to be with you in this respectable course conducted by MedExam Expert as usual.
Thank you, sir.
So I think we have some questions on the chat room. So
Box.
can we
That
go
is there
to
any
answer
exemption
first?
for EBCOG, like part 1 of MRCOG, anything like that?
I think no, because
Or
MRCOG Part 1, now you have to understand the differences between fellowship and membership. Okay. The European Board and College providing a
Fellow.
certificate of fellowship Fellowship means there is almost no step regarding basic science. So in MRCUG, part 1 is related to basic knowledge, part 2 clinical knowledge, part 3 applied clinical knowledge. Okay, in EBCUG, part 1 is obs and gynae clinical knowledge. There is no basic knowledge, most importantly. So the part 1 MRCUG never equivalent to part 1 EBCUG. You mean part 2 maybe, but this is not allowed up till now. Am I answered it clearly for you? I wish I did.
Yes, Dr. Saleha, I hope that it is clear.
So Osama said, is there any experience required for exam? You have any input, Dr. Desiree, or?
Yes, sir. It's 4 years experience.
Actually, yes, exactly. If you would like a proper answer, exactly like what Dr. Desiree said, 4 years experience prior to go for part 1, but you need experience not only for just attending the exam. You need experience to be able to answer the questions. Questions are not just answered by knowledge and studying. There are many questions in exam depending mainly on your clinical practice and experience. So when we are advising candidates to have a proper training and experience as much as they can prior to go for any exam, this is not just to fulfill some papers of entry or all of these staff requirements. No, we are advising them because you will need clinical experience and practice to be able to answer many questions. It's not all about knowledge, you know. You have to be able to how to utilize your knowledge. So what is the benefit we can gain if we became European fellow in terms of license practice in Europe? Okay. Up to my knowledge, it depends on every country in the European Union. So France is different than Germany, is different than Romania and other countries. You have to fulfill the criteria of each country, requirements of practice in each license practice in each country. But the benefit is you will be shortcutted to your career in ops and gynae in whatever the country you went for. Okay, you go for. So and instead of trying to find a job and a recognized certification and all of these stuff, license is different than certification. So for example, I am MRCUGian, okay? So I can easily work in UK. But if I'm only have MRCUG, I have to find a license way to recognize the British certificate in Egypt, because I'm from Egypt. Okay, they will never, let me work because I'm licensed in UK. I have to gain the license of Egypt itself. Then I will follow easily the legal steps of license according to my country, but they will approve and recognize MRCUG because this is a recognized, prestigious, well-known certificate. So license of practice in Europe, it's different from country to another one. Dr. Zizi, would you like to add anything else?
That's the language, sir.
So I just not to waste any time for people. I know this is the Friday weekend, Eid, and all these stuff. So you have a lot of preparation to be done. I will go directly just to share a kind of what we are going to do in our course. Just I choose a very strange topic for most of candidates. Even those people who attended the MRCUG before or whatever FPS in Pakistan or in India, most of obstetricians and gynecologists, they have no idea about breast lesions. But in European board and in Europe, breast is a well-known organ to be very well known by obstetrician and gynecologists mainly. Okay. That's why you may find some questions in your exam related to breast masses. So we have to, I will show you that we are very targeted and focused on points related to the exam perspective. I'm not going to, me or Dr. Desiree, by the way, we are not going to give you a lot of knowledge and information and all of this stuff because of the knowledge. No, we are giving information because of the exam. So we will be too much focusing on the exam ideas and exam perspective. Okay, so everything will be summarized, everything will be targeted. So this will be more helpful for all of you to just be able to revise and summarize easily. What are the differences from your idea between benign masses and malignant breast lesions? So simply, we all know that the benign lesion everywhere in the body are characterized most probably by smooth, rounded, well circumscribed borders. Okay. On the other hand, if we have irregular borders, sharp edges, speculated margins, this is more suggestive for malignant lesions. By ultrasound, the hyperechoic lesions of the breast are very benign. Okay, the hyperechoic, more than the breast tissue and fat tissue, this is very benign. While if the hyperechoic lesion is associated with some shadows, okay, or calcification, now the scenario is different. This is raising up more and more the risk of malignancy. Okay, the mobility and compressibility of the breast lesions, by the way, if it's mobile and compressible, so this is a benign breast lesion. If it's not mobile or fixed mass, so this is malignant. And finally, if the mass is not receiving vascularity on Doppler studies, it means most probably it's benign. And if it's associated with high vascularity, so it means that there are a kind of neovascularization is occurred around the mass. So this is raising up the risk of malignancy. So fortunately, 90% of breast lesions are benign. Don't be afraid. You have to reassure the patient most probably and revise the risk factors of possible breast cancer. Despite breast cancer is the most common kind of cancers in women worldwide, but still 90% of breast lesions are benign. They are varying between very common fibrocystic changes, less common benign fibroadenomas, maybe less and less common conditions like traumatic necrosis of some breast tissues and all of this stuff. The fibrocystic changes, the most frequent lesion in the breast. Why? Because it's simply related to the fluctuation of body hormones. Okay, the fibrocystic changes are related to ups and downs in estrogen, progesterone. Okay, so you will find fibrocystic lesions in extremes of age, and sometimes in middle age with pregnancy, lactation. So you will find a lot of lesions related to fibrocystic changes. What kind of diagnostic tools we have? in our options to assess breast lesion. Let's say mammography and ultrasound. They are very common and basic imaging tools. Don't try to think about MRI breast, for example. It's important, but it's not the baseline imaging tools. If you would like to understand rather than just memorize some answers, the ultrasound scan is very important in young ladies. Why? Because in young women, the breast consistency is depending mainly on fat and adipose tissue, while the fibrous tissue is very limited amount. But in old women, menopausal women, the fibrous tissues in the breast are more abundant than the adipose tissue. The ultrasound scan is ideal to assess soft tissues, just to differentiate is this mass is hard or cystic. If the mass is hard, this is raising up the risk of malignancy significantly. While if it's a cystic lesion, this is more probably very benign breast lesion. The mammography is critically important in women with fibrous tissues more than adipose tissues, while ultrasound is more important in women with adipose breast tissues more than fibrous tissue. Got my point? So less than 40, we used to offer ultrasound scan. If we have anything suspicious, we can offer also mammography. But in above 40 patients, we have no other choices rather than combined imaging tools, mammography and ultrasound. Okay. This is the cystic changes in mammography. And this is, for example, a cystic lesion in the breast. Clear cyst, well circumscribed borders, clear contents with hyperechoic findings. Multiple breast cysts. There are also, on the right side, there are also some locularities in the cyst itself. I think this is more convenient with early abscess formation. Now, again, the most common question related to breast benign problems in ABCOG, in MRCOG, in ACOG, in everywhere is mastitis, inflammatory process of breast tissue. Why? Because this is very common. It's very common, especially in postpartum period. Now, it's very important landmark to know that mastitis with non-lactating women is extremely rare. And it's very suspicious because we have a very aggressive kind of breast cancer is known as inflammatory carcinoma, or the official name is mastitis carcinomatosa. It gives the same picture of inflammatory breast. So if I have a patient in my clinic, she said, I just have a redness, hotness, tenderness in my right breast, for example. Okay. My question is, are you lactating or not? If she said yes, I don't care. I will give her the treatment and wait and see and all of these stuff. If she said no, I'm not lactating, I will take a biopsy. Straightforward. No way. Because it's very confusing in clinical assessment to differentiate between inflammatory cancer and the regular or original mastitis inflammatory process. Okay. The mastitis is a stage of inflammatory process that requires medical treatment and follow-up. What kind of treatment? Antibiotics in the form of penicillin family, hot fomentation, tight clothes, somehow and non-steroidals, anti-inflammatory medications as well. And then within a week, if the situation is not settled, abscess may be developed. And all of you knows the answer of treatment of abscess. Once the abscess is developed, drainage is the only way to be managing this condition. Okay? So the ultrasound scan is enough to confirm if there is any abscess underlying cause with this mastitis or not. With the mastitis, puerperal mastitis, the main organism is staph organism, Staphylococcus epidermidis. That's why we choose penicillin family as an antibiotic of choice, because this is the ideal option for Staphylococcus. Particularly, if you need to be more accurate, particularly floccloxacillin. Floccloxacillin is the best option for staph epidermidis soft tissue inflammation and infections. This is to be very accurate. Other differential, which may be may be presented in non-postpartum patient, it could be like plasma cell mastitis, granulomatous mastitis, and other granulomatous infection with inflammatory breast cancer. In mastitis, you may find a very significant also associated problem with inflammatory axillary lymph nodes. Inflammatory axillary lymph nodes, ipsilateral with the lesion. Okay. The complication, as we said, if not treated well or not responding to treatment, breast abscess formation. Now, this is the diffuse lesion of mastitis. This is the diffuse lesion of mastitis. There is no well-defined mass can be detected or lesion. It's ill-defined diffuse lesion. And here is the abscess cavity formation with turbid contents, as all of you can see the heterogeneous contents instead of jet black clear contents. Abscess. The second very common in also lactating women is a benign breast lesion known as galactocele, typically occurring in young lactating women. And it's also may be developed into breast abscess if secondary infection happened on top of it. Okay. What happened exactly is a retention cyst in the lactating ducts, leading to the occlusion of one of these ducts and then collection of milk inside galactocele happened. It's very painful, by the way, and pain is a good sign to differentiate between the benign lesions and malignant lesions. Malignant most probably are painless, unless in few situations. In ultrasound scan, most probably it's a cystic lesion, sometimes cystic plus solid components, because the fluid inside may become harder than expected with accumulation, and aspiration is recommended in the first instance, which will classically yield milk fluid. This is to confirm the diagnosis. Okay. Later on, if not spontaneously resolved, which is very common in these cases with conservative management, excision of the tubule overall may be the ideal option. Okay, now you can see the galactocele, the circumscribed mentioned by both arrows. Okay. What about the hamartoma? Just a second, please. I will be with you. Just a second. Okay. So what is meant by hamartoma?
Hello, Dr. Hassan. I cannot hear you.
Oh, sorry. Yeah,
Yeah,
the
I
mic
guess
was
that you were
closed.
muted.
I'm just keep. Thank you for informing me. I kept
No
talking
problem.
while the mic was closed. So you know that the hamartoma,
Yeah.
the last thing I said, hamartoma is the breast inside the breast. It's exactly like breast tissue with circumscribed mass inside the breast tissue because it's formed of the adipose, fibrous, and connective tissue, glandular tissue. Okay, hamartoma, it's capsulated, painless mass, and it's benign. So would you like to remove it or to just keep eyes on it? What would you like to do with this mass? How would you like to manage? Give me your inputs, please. Now, this is a very important thing to start the proper way of thinking regarding questions in exam. So let me summarize this in there is no fixed evaluation can be considered in anything in medicine. Individualized management, customized management is the best way to evaluate. So if you discovered a hamartoma in 25 years old woman, is the management is different if the same lesion are presented in 60 years old woman? Definitely yes. Okay. In 25, I can give her another look after 6 months. Okay. Just to check the size, any changes inside the mass, or all of this stuff. But in old age woman, I will never hesitate to remove it and send it for histopathology. Okay. Why? Because with higher age, the risk of malignancy is higher. Another point to be considered, that hamartoma, by the way, is noticed to be associated with some inherited tumors, and some congenital defects related to cancers, like Cowden's disease, a rare inherited disorder marked by the presence of many benign, not cancerous growth called hamartomas, and increased risk of cancer later on, especially in skin lesions, breast, and gastrointestinal tract. Okay, this is because of genetic defect. So Cowden's disease with hamartoma, suggesting strongly that you need to remove it and analyze it. Then, if a woman had a trauma in her breast, the benign non-suppurative inflammatory process of adipose tissue will start, and it leads significantly with fat necrosis, which is ill-defined, speculated, dense lesion. Unfortunately, it may be also associated with skin retractions, which is highly suspecting underlying cancer of the breast, but actually it's definitely benign lesion. In breast ultrasound scan, the fat necrosis is hypoechoic mass with well-defined margins, and the mammography most probably will be not suspicious. This is the picture. It looks very suspicious. I'm right? But this is the importance of proper taking history from the patient prior to start any kind of investigations. If we would like to classify the breast masses finally with WHO classification, the vast majority of breast cancers are adenocarcinomas because of the glandular underlying structure of the breast. The most common types are invasive duct carcinoma, invasive lobular carcinoma, which is very aggressive and characterized by bilaterality, okay? And other non-epithelial malignancies like malignant phylloids, metastases, and breast lymphoma. Just a summary for neoplasms, because it's somehow far away from your an uncommon topic in your exam. The breast benign lesions are more common. The neoplasms, we have a fibroadenoma, which is benign and the most common lesion in the breast, as we said, but it may turn malignant in some other types of fibroadenoma. Let's say that, just to remember, the fibroadenoma may turn malignant, and the Epstein-Barr virus particularly may be a causative organism and rule in the development of breast tumor with fibroadenoma in immunocompromised patients. The central papilloma is the most common subtype of breast tumors, okay? The invasive papilloma. And the management definitely is by removing the breast tissue. Imaging is not important. Papilloma and papillomatosis, it's a central retroareolar lesion and it's significantly and characteristically associated with bleeding per nipple. This is the key word. Once you see it, you have to remember the papilloma. You have to remember the papilloma and papillomatosis cancer. This is the key word, especially in young women. Sometimes serous discharge is a very important landmark with bloody discharge to diagnose this case. So this is the key word. The phylloid tumor is a very aggressive tumor. It's cystosarcoma indeed. And the treatment is by full breast removal. It's fortunately locally invasive tumor. You know that we have a lot of tumors in our bodies that they are just locally invasive tumors. There are no metastases. One of them is phylloid tumor. Basal cell carcinoma or rodent ulcer is locally invasive. Desmoid tumor of the muscles is locally invasive, and phylloid tumor as well. Okay. So after wide local excision of the lesion, okay, there is about 25% of possible recurrence, very rare, less than 10% risk of metastasis. And finally, the lipoma is a very benign lesion of solitary tumor of fat origin or adipose tissue origin. Sometimes it's mostly firm, but it may turn hard in consistency, simulating the cancer lesion. However, if you have any doubt, you can just go for fine needle aspiration or true cut biopsy to confirm your diagnosis. This is all topics in one presentation, 20 minutes. If you went through the presentation one more time, you will be very efficient in differentiation of different kinds of breast lesions, either benign or malignant, and you will be able to answer more than 90% of questions clearly in your exam and your preparation as well. Thank you so much. I think it was targeted, as we said. And Dr. Desiree, are you still here?
Yes, sir. Very nice lecture. You know, you have covered one syllabus already in the gynecology module.
Yeah, we finished one of the important topics in syllabus,
Yes.
the breast lesion in gynecology. I wish it was simple and it was straightforward presentation, helps everyone to remember the most important lesions and particularly benign lesions because they are somehow more common, definitely, than malignant lesions in your exam. Any questions? So if there are no questions, it means either I'm a good teacher or the topic is very easy.
No, it's a very difficult topic, sir. You know.
No, but I think it's somehow if candidates would like to, or our friends would like to start answering some questions about breast lesions, they will find no more information needed for their exam regarding
sir.
this. I
It
was
makes-
very happy to
Dr.
conduct
Hassan,
this
I have a-
presentation.
Dr. Hassan,
Yeah.
I have a question, one question about when we have a breast discharge, if it's blood discharge, if it's unilateral or bilateral, it is serious in case you have papilloma. Which one is more serious?
Now let's put a rule, my friend. Most probably bilateral problems are benign. Okay. If you have if the patient called you, I have bilateral leg swelling after delivery, would you like to think about DVT?
Rarely. It's so rare.
Rarely. So the first impression is it's like positional edema. Check your blood pressure. You have any fluid retention or something? You understand me. But if she said my left cuff is extremely swollen and it's too much tender and red,
Yeah.
now please,
Yeah.
I have no other options rather than DVT.
Yeah.
So it's exactly the same. If you have a bloody discharge bilaterally, number one, most common cause, physiological withdrawal bleeding. Okay, you can find some, neonates with something like this, vaginal bleeding or bleeding sometimes from other orifices of discharge. Now, number two, you can think about bad general condition or bleeding disorders. Now, after that, it's extremely rare that the patient have invasive papilloma bilaterally in the same time. So most probably, we are thinking about general and benign problem. Malignancy most probably is unilateral.
Okay, doctor. So in such condition, we'll refer her to the breast surgeon?
It's typically, you have to go for, if the patient age is more than 40, mammography and ultrasound. Then you can refer the patient.
Okay.
If the patient is less than 40, at least you have to go for ultrasound scan first prior to take the decision. Finally, why we didn't offer MRI easily? Because MRI is difficult examination, despite it's accurate, but it's difficult examination. Just a second, please. Okay, so the last point I would like to mention is the MRI is expensive and difficult examination, by the way, imaging tool. So we should preserve MRI in certain scenarios. Let's say number one is the preferred number one option in follow-up breast bed after surgery. After surgery, after mastectomy, if I would like to follow up the bed for metastasis, MRI is the best option. What is the other scenario for MRI as the first option? Breast with implants. The ultrasound will be very difficult. The mammography will miss many information. So MRI is ideal with augmented breast with implants in women. Okay? So these are mainly the two indications of MRI of the breast. However, there is a third scenario that if we have a highly suspicious cancer patient, she opted for a surgical management. MRI can be requested by the surgeon to evaluate typical extension of the disease. So the decision regarding the surgery, is it lobectomy? Is it lumpectomy? Is it modified radical mastectomy or total radical mastectomy? This is sometimes requested by surgeons. Okay?
Okay.
I wish I answered your question clearly.
Yeah, okay, doctor.
Thank you so much. Thank you for your question. Okay. Dr. Desiree, the mic is yours, as you are the leader of this course, by the way.
Thank you, sir. Thank you for your time. Thank you for sparing your Fridays for us.
Thank you, and wish all of you a very happy Eid. Enjoy the vacation. Don't
And happy
study
Father's
anything.
Day.
Don't study anything. Try to eat a lot of meat and enjoy with the family and friends, and leave the study right now, preparation, and just keep the good spirit and ambitious mood so that we can start our course and our mission in a very good mood and in high motivational attitude. Thank you so much, all friends in this room today.
Thank you, sir.
Thank you so
Don't go
much,
yet.
Dr. Hassan.
The team will be telling you how to register for the courses and will give you a big discount. Okay, so please stay for 5 more minutes. You
Yes,
can
so
go ahead,
thank you so much, everyone. Yeah, thank you, Dr. Desiree. Thank you, Dr. Hassan, for such a great webinar. And we wish and hope that every participant got the answer for their queries about EBCOG. And most of the comments show that they understood the point from both the mentors. And thank you so much, everyone, for joining. And as we are clear that why should one join EBCG or what are the benefits, so we must share the news that we are going to announce the course and how to register about that. And also there is going to be a discount offer. So any student who wishes to join that, they can. So the team member will now soon guide. So Aisha, you can just start sharing the screen and you can announce about the course and how to register and about the discount that is ongoing for the Eid.
Hi everyone. Hi Dr. Hassan. Hi Dr. Desiree. Am I audible?
Yes, Aisha. Hello.
Hi, how are
Hello,
you?
Aisha. How are you?
I'm good. Thank you so much. How are you, Dr. Hassan?
I'm fine. I'm fine. Happy Eid. I'm fine. Thank you, Aisha.
Thank you so much, everyone. Thank you so much for joining us today's webinar. I'm Aisha, course coordinator from Team Exam Expert. So I'm here to guide you about our website. As many of you already know about Exam Expert, and recently we are going to start our new batch of Ebcog Part 1 with our brilliant and combo of mentors, Dr. Hassan and Dr. Desiree. So here is the procedure. Firstly, you have to register for Ebcog Part 1. You can visit our website, medexamexpert.com. And there is the number is already available. If anyone of is not reaching out and unable to log in, you can contact on this number. So I'm here to guide you, everyone. So here is the few different steps. Let me guide you one by one. You can visit our MedExam Expert website, go to the MedExam Expert LMS, find EPCOG Part 1 Intensive August 2024 batch. So here is the screen available. So you will find the EPCOG Part 1 Intensive course easily. Third step is click on Intensive course. You can go through. There are the different steps for the payment. Payment number one is the full payment. Secondly, you have two other options, installment options or the one go payment. So it's your choice what you want to avail. Then add to the cart, click on checkout, select your payment mode if you want to pay in a one go or you want to avail in the installment option. So you will have the different steps. So you will go through one by one. At the end, you can add the card details and enroll in our course. So for the webinar attendees, thank you so much for joining us as we are in the new days, 8 days, and we are offering a good discount for our students. All the students who are joining us in today's webinar, they can avail a good discount. In the screen, I have shared already a coupon, EAT AUG24. Everyone, you can take a screenshot and share the screenshot in the given number. So I will share the complete link with you and you will get a good discount. Also, those students who want to join us in a group form, means 3 or 4 friends want to join us and get the complete course with our mentors, then definitely for those we have a good special discount and they can avail a discount and join us from now and get the complete details and complete course material from now till the exam date. And here is the detail number already given in the screen. Any one of you have any query or anything you are unable to understand, you can directly contact me or you can ask from any team member of MedExam Expert. We are here to guide you. And one more thing, the discount offer is only limited for some time. So if you want to avail, then please try to join us and avail the discount offer from pocket friendly. So you can have a complete course. So you and to start your preparation. So this is from my side. Thank you so much, and over to you, Dr. Desiree.
Okay, guys, I think that's about it. Thank you for joining us in the course. And those who are interested, please just contact the team in the numbers written on the screen. Okay, Aisha, Anam, thank you, Dr. Hassan.
Thank you
Bye.
so much, Dr. Desiree, Dr.
Thank
Hassan,
you
and
so much.
everyone. Thank
Thank
you
you,
for joining
everyone.
today.
And I'm very happy again to join all of you. Stay safe and enjoy your time. Happy Eid one more time, and see you all. Bye
Happy.
bye.
Bye.
Bye-bye. Thank
Bye.
you.